Hi everybody, Dr. Ryan here again with another hard-hitting video in internal medicine. Hope you and your family are well. Thank you for subscribing to my channel, liking and sharing. I really appreciate all of you. This is our second video in the series where we're looking at a conceptual overview of topics in internal medicine. And we said that by and large, the different parts of the body, the different disciplines in internal medicine are neurology, cardiovascular, pulmonology, or respiratory if you like, gastrointestinal, renal, and then we had endocrine, hematology, infectious disease, rheumatology, and some general issues where we talk about geriatrics and so forth. So in this particular video, we're going to cover the C to the V to the S, cardiovascular, right? So a nice conceptual way of thinking about cardiovascular pathologies, etiology-wise, is first up to start with the endocardium, right? Then is the myocardium, followed by the pericardium, right? And then, of course, we have the aortic syndromes, and we have arrhythmias, right? So conceptually, first, let's talk about the endocardium. So where can the pathology be in the endocardium? So obviously, in the endocardium, we're talking about the valves, right? So you got stenotic and regurgitant lesions in this mitral, tricuspid, pulmonary, and aortic valves, right? So conceptually, you can have mitral regurgitation, which gives you classically a pansystolic murmur, which radiates up into the axilla region out of 6. Mitral stenosis, which is a mid-diastolic murmur. It's a rumbling, low-pitched murmur, best appreciated with the blood of the stethoscope, graded out of 4. Associated often, if there's patients in sinus rhythm, with pre-systolic accentuation of the murmur, with a loud first heart sound and with an opening snap. Okay, then tricuspid regurgitation, as we know, is a pansystolic murmur over the parasternal heart border, usually in the fourth intercostal space, all right, and it's exacerbated on inspiration. And tricuspid stenosis, don't forget about aortic regurgitation, which is an early diastolic murmur, often heard parasternal in the fourth space, left and right, okay, and is associated with a lot of eponymous signs, but the most important other clinical signs would be the water hammer pulsation and the white pulse pressure and aortic stenosis as well, which you can hear in the aortic area to the right parasternal second interspace radiates up into the axilla. Okay, and then of course you've got pulmonary regurgitation and pulmonary stenosis as well. Remember, tricuspid regurgitation often in the context of pulmonary hypertension. Okay, so what are the etiologies of valve problems? So of course we have the infamous rheumatic fever, which licks the joints but bites the heart. Okay, it causes transient arthritis, but it usually damages the heart valves on the basis of molecular mimicry. And we have the modified Jones criteria, or we have the Jones criteria, I beg your pardon. And Jones is actually an acronym because the major criteria is J for joints, speaking to arthritis, always obvious. So you can have a pancarditis. It can be endocarditis, myocarditis, and pericarditis, or a mixture. N is nodules, being subcutaneous nodules. E is erythema marginatum, S is Sydenham's chorea. Those are the major criteria, and the minor criteria is cafe pel, right? So if you can just write that down, major equals Jones, and minor equals cafe pel. C standing for raise CRP. A is for arthralgia, not arthritis. Arthritis is major. F is for fever. E is for raise ESR. P is for PR prolongation. A is for anamnesis of rheumatism, speaking to a previous history of joint disease and leukocytosis. So we have one major and 3 minor, or all 5 minor, that gives you diagnosis of rheumatic fever together with evidence of the strep infection. So you can do a anticephalized otiter, you can do a throat swab, and so forth. And of course, we have infective endocarditis, right? And the criteria we looked at there is the modified Duke criteria. So the major criteria here usually has to do with either blood culture or echo, right? And you got typical organisms which cause infective endocarditis on persistently positive blood cultures. So we know, right, this group A, beta hemolytic strep, it's Staph aureus, there has a group of organisms and a couple others. Echo, of course, will show you vegetations on a valve, or may show you a root abscess, or may show you dehiscence of prosthetic valve, and so forth. And the minor criteria is basically somebody who has a predisposition to a valve lesion, like an IV drug user, patient who has fever, a patient who has immunologic criteria, and vasculopathic criteria. So their immunologic criteria is things like glomerulonephritis, things like rot spots, okay, Osler's nodes, right? Splenomegaly, and then of course the vascular ones being like patients who have cerebrovascular accidents, who have a peripheral vascular disease, splinter hemorrhages, and so forth, right? And then of course the other minor criteria is blood pressure criteria, which don't meet the major, and echo criteria, which don't meet the major. That gives a diagnosis of infective endocarditis. Obviously, if you've got two major, definitely one major, two minor, possible. If you've got all five minor, there we go. Infective endocarditis, right? And don't forget about Libin sacs endocarditis, which is not like a clot per se, not a vegetation, but it's more. Rather, it is. Sorry, I beg your pardon. It is a clot in the setting of systemic lupus erythematosus, right? So SLE causes LSE, Libin sacs endocarditis. Okay, now let's talk about the myocardium. What possible pathologies can be hiding out in the myocardium? Well, most likely you have dilated cardiomyopathy, right? Because there's three flavors, right? Dilated, hypertrophic, and restrictive. And the dilated most often is in the back of ischemia, right? So ischemic cardiomyopathy, patients who had acute coronary syndrome before, they had a heart attack before. Don't forget about hypertension, which can also cause cardiomyopathy, as can alcohol. Alcohol is another big cause. It could be arrhythmia induced, patients who have chronic AF. Don't forget about peripartum as well, peripartum cardiomyopathy as well. Then, of course, we get hypertrophic obstructive cardiomyopathy and restrictive as well, right? And then what about pericarditis, guys? Pericarditis, okay, so you know that the patient will have typical ECG changes, chest pain, yeah, concave up, saddle shape, ST elevation globally, right? So the patient can have acute pericarditis, we can have pericardial effusions, okay, and they can have cardiac tamponade, right? When the patient becomes hypotensive. And that's when we talk about Bix triad, right? The muffled heart sounds, the raised JVP, the hypotension, right? And by and large, what can cause pericarditis are the five T's. The five T's being in our setting here in sub-Saharan Africa, tuberculous pericarditis is probably the most common. Trauma as well, post-trauma can cause it. Tissue being connective tissue diseases, right? Collagen vascular diseases, right? And then, of course, therapy in the way of chemotherapeutic agents uh, and tumors as well. So that which metastasizes to the actual pericardium. Okay, then we talk about aortic syndrome. So, what can actually cause aortic issues is aortic root dilatation. And we see that in the setting of cystic media necrosis, syphilis, ankylosing spondylitis. An aortic dissection is always, conservations, aortic root dilation, often concomitantly with aortic regurg and aortic dissection as well. Right. And then, of course, arrhythmias is our next stop. Arrhythmias. How do we classify arrhythmias? Arrhythmia is always a difficult word to spell. Arrhythmia. Okay. Now, these are always difficult to classify, but the useful starting point is whether it's bradyarrhythmia or tachyarrhythmia. So, tachy is above 100 beats per minute, brady is below 60 beats per minute. And then we go on whether it's wide or narrow complex, right? And then whether it is regular or irregular. Okay, but the most common one in our clinical setting that we see is atrial fibrillation. And we know the main signs of atrial fibrillation clinically would be an irregular pulse, irregular in terms of rhythm and volume. You have absent A waves in the JVP. You have abnormal intensity of the first heart sound, and you have a pulse deficit. All right, so that's in the way of arrhythmias. Okay, so guys, conceptually, once again, cardiovascular, we said that we have endocardium, myocardium, pericardium, aortic syndromes, and arrhythmias. And endocardium has stuff to do with the valves, right? We mentioned the different valve lesions. I'm looking mostly on the back of rheumatic heart disease, but also we need to know about infective endocarditis and some merantic endocarditis. The myocardium, we spoke about dilated cardiomyopathy, a bit of hypertrophic and restrictive pericarditis, we said can be acute pericarditis, which can lead to pericardial effusion, which can become bound down as constrictive pericarditis, but it can also have tamponade in the mix. And we spoke about the five T's of pericarditis, aortic syndromes, and arrhythmias. Okay, my friends, in the last video, we spoke about the first key spiritual lesson for growth in Christ, and that was we should never ever doubt the love that God has for us. The second one is from Isaiah 50, verse 4. It says, "You have given me the tongue of a disciple. You waken me up morning by morning so I can hearken to your voice and know your will." It's important for us every day to start with God. That is so important to sit at his feet and listen to his voice because that is the one thing that is needful. God bless you, and I'll see you soon. We'll be discussing pulmonology next. Take care and goodbye.